John here from bootcamp.com. Welcome to another lesson. In today's lesson, we're going to be taking a look at the neurons which are going to comprise the descending pathways. Now, there's two neurons, and we refer to it as a two-neuron chain. There's an upper motor neuron and a lower motor neuron. You can take a pause right here and take a look at the details of today's lesson, but let's just get started. So in order to understand the descending motor pathways, we need to understand the neurons that are involved in them. And there's two neurons. We have an upper motor neuron and a lower motor neuron. Now, the upper motor neuron, as the name would suggest, is going to be found in higher cortical areas. These are the cell bodies of these are going to be located in the motor cortex or the brainstem. So you can see we have this purple neuron right here coming from the primary motor cortex where motor movements are going to be planned. This is then going to descend down through the brain and the brainstem through the spinal cord, and in this illustration, it decussates, which means it crosses over. Then going to continue to descend down the specific spinal tract for that type of movement. And it's going to synapse in the ventral horn of the spinal cord at a specific level for the muscle that it's going to try to control. And where it synapses is it synapses on these lower motor neurons. So our lower motor neurons, as the name suggests, are going to be found lower in the central nervous system. And these are going to be found at the level of the spinal cord for which that neuron is innervating that particular muscle. So you can see we have this orange neuron here in the ventral horn of the spinal cord at a specific level. Let's call this one the cervical level. And it's going to exit out of the ventral horn through the ventral roots down through the spinal nerve, and it's going to go into the anterior or the posterior rami to innervate that specific muscle. So the axons of those lower motor neurons, as they leave, they're going to go to the muscle and they're going to synapse at the muscle at that neuromuscular junction where acetylcholine is released to stimulate that muscle to get it to contract. So we have our upper motor neurons here in purple, and we have our lower motor neuron down here in orange. Now, one thing I forgot to mention with the lower motor neurons, they're not always found in the spinal cord. They can actually also be found in the brainstem. And this is specifically when we're talking about the muscles or the cell bodies for the neurons, for the muscles, which control the muscles of the face. So the muscles of mastication, the muscles of facial expression, and so on. These are going to be coming out of cranial nerves. So these cranial nerves, of course, are going to be found in our brainstem. So the lower motor neurons for these pathways are going to be found here throughout the brainstem. So building off of that, in the brainstem, the lower motor neurons are going to be the cranial nerve nuclei. So let's say you have your facial nucleus, which provides motor innervation to the facial nerve and the muscles of facial expression. That cranial nerve nucleus is going to house those lower motor neurons. And the axons from these cranial nerve nuclei, these are going to exit, and these are actually what form the cranial nerves. So axons form the cranial nerves, which are going to travel to the target muscle. So let's say it's your frontalis muscle. Those cranial nerve axons are going to exit, form that cranial nerve, and that is what is going to go and stimulate that frontalis muscle. Now, these cranial nerve nuclei are going to be found throughout the brainstem, but the majority of the ones that we're going to be focusing on in later lessons are going to be found in the medulla, and this is because we have a lot of motor nuclei in here which are going to go off and create those cranial nerves which innervate the muscles. Now, we also have lower motor neurons found in the spinal cord. And as I mentioned, these are going to be found in the ventral horn of the gray matter of the spinal cord right here and right here. So as a neuron or an upper motor neuron descends down, it's going to come out and it's going to synapse on a lower motor neuron found here in our ventral horn, and then from the ventral horn, those are going to leave out through those ventral roots. So now that we've talked about lower motor neurons and upper motor neurons, let's look at them in the context of the stretch reflex arc. So what is the purpose of the stretch reflex arc? Well, it is to maintain muscle length. And how does it do that? Well, when the muscle stretches, we have sensory afferent fibers, which are going to send a signal back to the spinal cord, which will then synapse on the lower motor neuron for that muscle, which will then stimulate that alpha motor neuron to go and contract that muscle to make sure that muscle is not overstretched. So when we use a reflex hammer on the patella, in this instance, we hit our patellar ligament. This is going to cause our extensor muscle to stretch. And when this does so, the muscle spindle found deep within the muscle, this is going to send an afferent sensory signal back to the spinal cord. It comes in through the dorsal horn and then synapses on the lower motor neuron for this extensor muscle in the ventral horn. Once it stimulates this alpha motor neuron, this is going to send the signal to that muscle to contract. And what's that going to do? Well, it's going to extend the knee forward. Now, there's also another pathway which is going to send an inhibitory signal to the flexor muscles in the hamstrings to relax. So as the flexor muscles are relaxed, the extensor muscles are engaged, and this allows for extension of the knee joint when that muscle spindle is feeling a tension or a stretch on it. So we know that activation of the lower motor neuron is what is responsible for contraction of the muscle. So let's say we have damage to that lower motor neuron. What are we going to experience? Well, we're going to experience a loss of that stretch reflex because we no longer have this lower motor neuron stimulating the muscle fibers to contract. Now, what about the upper motor neuron? What role does this play? Well, the upper motor neuron is actually going to come down, and as it stimulates the lower motor neuron, it's going to provide some inhibitory responses to help reduce or modulate the extent of the reflex. So the upper motor neuron acts as a modulator for the lower motor neuron during that stretch reflex. So let's say we have a lesion to that upper motor neuron. What are we going to experience? Well, we're going to experience hyperreflex or hyperreflexia because we no longer have that modulation input or that inhibitory input modulating the lower motor neuron. That lower motor neuron is going to send more of a stimulus to those extensor muscles, and it's going to cause more of a contraction, which causes a hyperreflex or a hyperextension of the knee. Now, there are a few important levels which you can test with a reflex hammer to see if there's a lower motor neuron lesion at that point. We have our C6, which tests the biceps, C7, which is tested on the triceps, L4, which is the patella, which is the example we just walked through, and S1, which is at the Achilles. So now let's take a look at the upper and lower motor neuron lesions and how they affect the reflex arc. So if we have a lower motor neuron lesion, because we have no more stimulus to that muscle, what we're going to see is atrophy. So we have a loss of neurotransmitter signaling to stimulate that muscle. This is going to cause those muscle fibers to deteriorate over time, and this is going to decrease the muscle mass for which that lower motor neuron was stimulating. So no more stimulation, no more activation causes atrophy. It's also going to cause ipsilateral weakness if some of the lower motor neuron is damaged, and complete paralysis if all of that lower motor neuron is damaged. Now, we already talked about this, but you're also going to see hyporeflexia, which is going to be either reduced or complete absence of the reflex, and this is due to no more lower motor neurons stimulating those muscle fibers, so we don't have that alpha motor neuron stimulating that reflex when the muscle is stretched. So if we have partial damage, then some of it is going to be activating it and you'll have a reduced reflex, whereas if we have damage to all those lower motor neurons, then we'll completely wipe out that reflex and you will see absent reflex. We'll also have fasciculations. Now, fasciculations, this is essentially just twitching of the muscle fibers. And this is caused by spontaneous firing of action potentials at that neuromuscular junction, stimulating those muscle fibers, causing the muscles to twitch. And this is due when we have damage to portions of a lower motor neuron. It's going to cause spontaneous firing of those action potentials, and you're going to see kind of like twitching at those muscles. So those are called fasciculations. And then we're also going to see hypotonia, and this is decreased muscle tone because we no longer have signal. We no longer have that signal kind of maintaining the tone of the muscle. So what you're going to see is a decreased muscle tone in that area. Now, what happens when we have an upper motor neuron lesion? Let's look at these side effects one by one and compare them to lower motor neuron lesions. So we're not going to see any atrophy, and this is because that lower motor neuron is still intact. You're still going to have that signal coming from the lower motor neuron and stimulating that muscle fiber. So you're not going to see any atrophy. Now, what you'll also see is graded weakness or paresis, and this can either be ipsilateral or contralateral. So if the lesion for the upper motor neuron is in the higher cortical area, mainly in the primary motor cortex, then you're going to see contralateral graded weakness or paresis. Whereas if it's in the spinal cord, the lesions in the spinal cord, then you're going to see ipsilateral on the same side as the lower motor neuron. And this is because there's a point of decussation in the medulla, which we'll talk about in subsequent videos, where the descending motor neuron is going to cross over before stimulating that lower motor neuron. And again, we already mentioned this, but we're going to see hyperreflexia. We're not going to have that upper motor neuron input modulating that lower motor neuron. So this is going to cause a hyperreflex when that lower motor neuron is activated by that afferent sensory neuron. Now, we're not going to see any fasciculations. Remember, we saw fasciculations because we had spontaneous firing of action potentials at that lower motor neuron, but that lower motor neuron is still intact. So you're not going to see those random firing of action potentials, which is going to cause muscle twitching. So there will be no fasciculations. Now we're also going to see spastic paralysis and hypertonia. And in the affected limb, you're going to see increased muscle tone. And this is tested through that passive stretch test. So let's say we're looking at the upper limb and we have a upper motor neuron lesion for the lower motor neuron, which is going to be controlling this limb. When I try to passively stretch the limb, because I have increased muscle tone and hypertonia, it's going to be hard for me to passively stretch this limb. So you're going to see very rigid, jagged movements due to that hypertonia. Now, one key sign that we can pay attention to when we're looking for an upper motor neuron lesion is Babinski's sign. And Babinski's sign is seen by doing a plantar reflex test. So during this test, you're going to take a sharp instrument and drag it along the heel of the foot up the lateral aspect and across the toes towards the medial side. When you do this if there is no upper motor neuron lesion, the normal response would be curling of the toes and plantar flexing the foot. So we're going to plantar flex. Essentially, you're going to try to kick away that sharp object almost. So we're going to plantar flex and curl the toes. Now, if we have an upper motor neuron lesion, we're going to see kind of the opposite of that. The toes are going to extend and spread out, and we're also going to dorsiflex the foot, or kind of lift the bottom of the foot upwards. So this is a key indicator that is going to tell us if we have an upper motor neuron lesion, and this is known as Babinski's sign. Now, in infants, the opposite is true. Normally, what you'll see, if there is no upper motor neuron lesion, you will see this right here. You'll see dorsiflexion of the ankle as well as extension of the toes and spreading of the feet. And if there's an upper motor neuron lesion in that infant, you will see curling of the toes and plantar flexion of the foot. So those are just some key indicators to look for when you're trying to determine whether you have a lower motor neuron lesion in a patient or an upper motor neuron lesion in a patient. These are just some references for some of the images we used. But that's it for today's lesson. I hope you enjoyed it. We looked at upper motor neurons and lower motor neurons, the stretch reflex arc, and what happens when we have lesions at different points of the upper and lower motor neuron pathway. And we also took a look at Babinski sign and what to pay attention to. So I hope you enjoyed that, and I'll see you in the next one.